was probably the happiest kid you would ever imagine. My childhood was idyllic. Everything about it was the way a child should live. Or if it wasn't, I wasn't smart enough to know it. I had parents who had me late in life. They had had two boys, 10 and 7 years older than me, then a daughter, 6 years older than me, who died in her infancy of a crib death. My parents were devastated. My mother particularly was lost. She wanted to become pregnant. She couldn't. And then suddenly, 6 years later, along came me. So I was essentially an only child with two older brothers, raised by parents who, when I talk with my older brother, Don, he describes as different parents than the ones who raised him. And that was true. By the time I came along, my father was a business success. He was an executive with the Aluminum Company of America. My mother was a personal success. She felt fulfilled in life and particularly made it clear to me that I was the fulfillment of her life. She really wanted another child and she got one, and she was glad to have me, which was terrific. And they both made it clear that they were tired of being parents, so I'd better be an adult as a child, which was great because that meant they respected me as an adult, as a child. They didn't make me grow up too fast. I had a wonderful childhood. I used to get magic sets for Christmas, but instead of guessing, they would give me the FAO Schwartz catalog and say, you choose, here's the dollar limit that we're not going to go beyond, and you choose what you'd like. And so I chose magic sets or costume sets or whatever kids, or erector sets or chemistry sets, because I was sort of a chemistry nerd as a little boy as well. And so it was a very happy, fulfilled childhood. Instead of leaving me behind, they took me to the theater and the opera and the art movies in St. Louis, where I grew up. A very happy childhood. Dad worked for the Aluminum Company of America. He was a chemical engineer, and by the time I came along, he was already an executive with Alcoa. He was a war baby. He was born in 1940, so before I was 3, we had lived in, I was born in Pittsburgh, just outside of Pittsburgh. We lived in Vancouver, Washington, and Modesto, California, and then he got moved to St. Louis when I was 3, where he was the works manager for the Alcoa operation in East St. Louis. So he'd gone from being upwardly mobile and part of the war effort to a successful executive in my first 3 years. That wasn't the father my brothers knew. My mother was a trained educator, college graduate. She had been on the staff of Fortune magazine in the 30s. And then when I came along, she gave up her work and was just a so-called stay-at-home mother who never stayed at home. She was always out there volunteering, and she was particularly involved in international education and English as a second language, way ahead of her time in the 1940s and 50s, and a community citizen volunteer. So the parents I knew were wholly integrated into a positive experience themselves in the community, and they passed on that joy of life to me. In high school, there was absolutely nothing I wasn't interested in. I loved it all. I guess my favorite class was Latin because I could master it, and there was a structure and a sense to it, and I loved the sense and the sense beyond the sense, and getting into the absolute and then the ablative absolute and the pluperfect and trying to understand the structure of linguistics. I loved it. But I loved math too, and geometry particularly, and I loved English. And I had a wonderful English teacher who made a game out of similes and metaphors. And boy, did that teach us how to think beyond the words into the constructs. It was fun. So there was really nothing about school I didn't like. And I was a straight A student. I never thought of myself as particularly smart. In fact, it took my mother to tell me that I was smart, because it didn't occur to me. That was just not part of my frame of reference. Loved theater, particularly musical theater, sang in the school musicals and sang in the school chorus and did debate society and annual public speaking. I just loved it. The most important experience in my growing up, well, maybe it was getting cast in musicals and singing solos, because you do learn how to be a public presence when you do that. But I think it was being elected to the student court. I always thought I wanted to be in the student council. I wanted to be a social kind of guy. And my classmates didn't see me that way. Sometimes, as you know, the best insight into yourself is how other people see you. And my classmates saw me as oriented towards social justice, which I guess I didn't know. I mean, it didn't just automatic. It wasn't innate. But they showed me that I was, and boy, I loved the student court, and I loved thinking through tough ethical, social challenges and coming up with equitable solutions. Student court meant that in our school, each class had one person elected to the student court. The student court this was a high school, junior high school combination. So there was a 12th grader and 11th, who was the chief justice, and then 11th, 10th, 9th, and 8th grader. I was elected in the 8th grade and never wasn't on the student court. And we would meet to adjudicate tough issues that came before the student body. So somebody cheated on exams, somebody was being a bully, somebody was intentionally misrepresenting things. All of the things that are part and parcel of the human condition came before our court, and our job was to help them to understand the impact of what they were doing on the rest of us and come up with some kind of remedy. That's what courts do, and the student court did it for students. It was a great experience for a young boy who didn't really know that that was a unique experience. It just sort of taught me the power of peer understanding and social justice. As a freshman and sophomore, I studied German, and my teacher, Dr. Battenberg, left to go be an exchange teacher, the first American in a German high school after the Second War. He went over to Germany, and a German came over to teach us sophomore German, Herr Multhoff. And Herr Multhoff thought it would be just wonderful if he brought a student home with him. So I went home with him when I was a junior in high school, not to his house, but to an exchange family, and spent my junior year in high school in Germany. Now, these days, people just turn, of course, everybody's on AFS or whatever. I was a Quaker student, an American Friends Service Committee, sponsored student, and I was the first American after the war to set foot in Braunschweig, Germany. And the first American that anybody in the school had known, therefore, and the first American that the family who hosted me had known, although the father in the family had been killed by the Americans in the Dresden strip bombing of the Second World War, and the grandfather of the family killed by the Americans in the First World War. And the mother wanted her children not to hate Americans. Again, you stumble into these things in life, but what a life-altering experience it was. First of all, I didn't speak any German, so here was this loving woman who wanted her children to love me, and so she brought me along into the culture and the language and the history and the social justice or injustice of war and justice of restitution afterwards. It was a life-altering experience for me. So when I came back, my father had moved out to the Pacific Northwest. I started a new high school as a senior, having been an exchange student in Germany as a junior. And the headmaster, the principal of the school, introduced me in the first auditorium session, which was a little embarrassing anyway for a high school student. And I wasn't really listening because I was so embarrassed as a senior high school, and in a new high school, a public high school in Vancouver, Washington. But I had to stand up and say hello. It came across that I was German. He had said he's coming back from Germany and he's now here for a senior year, and I don't think he made it clear that I was actually an American. And so for the first 3 months of the school, everybody thought I was German, which was okay, because I had, and probably was easier, because if I'd just been an American, I probably would have been tucked over in a corner, but because they thought I was the German exchange student, they actually paid some attention to me, and I immediately got integrated into this marvelous high school in Vancouver, Washington. Well, probably more detail than you wanted, but what happens to us in those formative years really is instrumental in who we then become, isn't it? So there I was in a brand new high school, having to sell myself to a whole new group of peers as a senior in high school. So how do you go about doing that? Well, I did well in school. And that meant that others who wanted some help on their term papers or in the chemistry lab or whatever came to me because they thought maybe I could help them, which I could. And that was, needless to say, a blessing. But I digress. The point is, when my parents moved out to Oregon, I got accepted into Reed College as a junior. So I didn't have to go through the college search routine. I was already accepted at Reed College when I entered my senior year in high school, which meant it was a free year. I was in 5 plays. I ended up directing the high school musical, which was Carousel, so I know every word to every song of Carousel, which I will not sing on camera unless you want me to, although I do love some of them better than others. But it was a great experience. It was a rounding experience. Because they didn't know the old Hugh, and the only grades they had from Germany were pass, fail, pass, and because I got straight A's my senior year, I was tied with 3 others for valedictorian in the class. The 3 others never forgave me because they had worked 4 years to get their straight A's. I only had to work 1. But we've been lifetime friends, of course, ever since. That's also bonding, as you can imagine. Reed College was a school committed to a lifetime of learning. You didn't have to memorize anything. In fact, they prided themselves in never asking you for facts on exams. You had to answer any exam question with concepts that reflected understanding and perhaps creativity. But if you needed facts, those were always available for you to look up. It was just a great philosophy of education, and I loved it, and it stood me in good stead all my life. It was totally awful for going to medical school, which was all about memorization. But I was a German literature major. I spoke German fluently, so by the time, because I lived in Germany as a high school student, so by the time I was in my 3rd year, I was the only student in German 4, which meant that the professor and I would have lunch together once a week, speaking German, and I wrote my thesis in German. I read Thomas Mann in German and loved Magic Mountain, and it was just a great experience. But of course, I decided, I think when I was 10, that I was going to be a doctor. So, my life had sort of been leading up to a career in medicine. And I've never made any secret of it. I mean, that was just sort of what I wanted to do. So, but I didn't want to be a pre-med grind at Reed. So I was a German literature and biology major. The biology got me into medical school, and German kept me sane. Because I really wasn't as good at math and science as I was at languages, but I loved them both. That was all good. And got accepted to medical school after 3 years at Reed. So instead of graduating from Reed, the 4th year of Reed was my freshman year of medical school, and Reed agreed that it would give me a degree if I could show that I could complete 2 years of medical school. So went to Reed for 3 years and went to medical school, and at the end of my 2nd year qualified for the Reed degree. Washington University Medical School, and then first year postgraduate education internship, we called it then, now it's just postgraduate year 1, residency in medicine at Yale. I paid my way through medical school, got a scholarship, supported myself by drawing blood at Jewish Hospital in exchange for free food, got married when I was a freshman in medical school. So my wife and I both supported ourselves through this medical education. I supported her through her final years in elementary ed. She then went to work as a teacher and supported me, and we ate at Jewish Hospital on the blood drawing money. But as a senior in medical school, I'd run out of money. So I joined the Army. It was Vietnam, and the Army had a senior medical student program, which was wonderful. They paid your tuition. There were a lot of us who didn't have money. In exchange for a commitment of 3 years in the military once we were finished with our internship. So my senior year in medical school and my internship, I was in the Army on inactive duty as a lieutenant, which was great. It meant we got to go to the PX and buy cheap food. But then, of course, I had a military service obligation after my internship. So I took my internship in internal medicine at Yale. It was awful and wonderful. Internship in those days, 1965, was on 36 hours, off 12. So you were up for 36 hours, then you collapsed. Well, by that time, Judy and I already had Hugh Jr. He came along in my junior year of medical school. And so we moved to New Haven with Hugh Jr., And I was an intern, so I would go work for 36 hours, come home, get down on the floor to play with Hugh, and wake up the next morning for some breakfast. Judy said that she threw more dinners away than she ever imagined she'd prepare. That was our year in New Haven. Two other aspects of our year in New Haven. We lived right around the corner from the medical school, at the intersection of the Black ghetto, the Hispanic ghetto, and the old Jewish quarter, which was called the Combat Zone. It actually, the focus of it was at our house. So my first job as an intern at Yale, husband and father of a 2-year-old, was to get chicken wire and put it all around all of the windows of our apartment because it was so terrifying to live there. And it was fine. It was just fine. We made friends all around the neighborhood, including our best friend right across the hall from us, Jim Newton, who was a set designer at Yale. You may wonder why I'm telling you this detail. Well, there's a reason. That is, Judy became pregnant again. And we had our wonderful second child, Josephine, named after her grandmother, while I was an intern at Yale. And just like my sister Annabelle, Josephine died at 3 months, also of a crib death. There is no way I can find the words to tell you what it felt like to lose a 3-month-old. Under those circumstances, in the middle of internship, with my wife home alone, with chicken wire all around the house and a 2-year-old in diapers, it was world-shattering. But you know, you go on. The evening, I got a call. I was on duty on one of those 36-hour marathon, actually it was worse than that. It was 72-hour marathon weekend at the New Haven Veterans Administration. Got a call from Judy, who said, I think Josephine, Buffy, we called her, is dead. Can you come home? And so I did. And she was. And we went on autopilot and walked this sweet little infant to the hospital, to the emergency room, and said, we think our child has died. Please confirm it and help us to do what we need to do. Now you'd think, as a physician, graduate of Washington University Medical School, on the staff of Yale, I would have known what to do, but I don't think anything could have prepared me for that moment. And the hospital simply threw its metaphoric arms around me and said, of course we will help you and we will make this good. And they took her, and that was it. We walked home, and as we were walking home, there was a little parochial school between the hospital and our house, and we heard a classroom of little girls singing hymns. We went and sat in the back row and grieved. But there were these little children singing hymns. And so it was already better. We got home, and our next door neighbor, Jim, who had been the godfather of our child, threw his physical arms around us and said, it'll be all right. And in those days, it wasn't all right to come out when you were gay, but he did, and said, and I know you believe in Planned Parenthood and thought that 2 was the only number of children you could have, but I'm gay. He actually said I'm homosexual. You can have my 2 also, because you'll be great parents. And he gave us his quota of children to make. And that was healing. Then in the evening, we were sitting there staring at each other and at the floor and had put our son to bed. And there was a knock on the door, and 30 people from the hospital walked in and let us know that we were never going to be alone. Well, you know, in terms of life-altering experiences, to understand that in all of the hardships of life, we're never alone is just critical. And this we learned. So that was internship. The person who was our lead, the department head of medicine, made it clear to me that I wasn't cut out to be an internist. He said, you know, you're smart and you're nice and you'd be a good internist, Hugh. He was not cruel after all. But really you think too much about people in community and family and root causes of things to be, for medicine to hold out the interest for you, you really need to go into public health. And beside that, you're going to be going to Vietnam. And if you go into public health, you'll be a preventive medicine officer and you will be good. So he got me an appointment for the Office of the Surgeon General. I went down to Washington, interviewed for the Preventive Medicine Service. They liked me and what I had to say. And oh yes, found out that I spoke fluent German. I didn't go to Vietnam. I was a preventive medicine officer in Germany for 3 years during Vietnam. All thanks to my mentor, Paul Beeson, and an internship at Yale in the wrong medical specialty. In 1965, when you went into the medical corps, as a one-year trainee out of medical school, they sent you to Fort Sam Houston, Texas, to become an instant expert in military medicine, so-called medical basic. Now, we had to learn how to wear a uniform and which brass goes where, because there'd be no reason why a physician would ever know how to march in step, probably chew gum and march at the same time, crawl on our elbows and knees under live bullets and barbed wire at Camp Bullis, and toughen up a little bit because we were going to Vietnam. I went to the preventive medicine basic course at Fort Sam Houston, Texas, during which they taught us things that you never learned in medical school, and certainly no internist is properly taught about how to prevent illness, with the dignity that preventing illness is far better than having to treat it. And that's everything from trench foot and fungal infection and other jungle-related injuries and toxic exposures in Vietnam to sexually transmitted diseases when you're on R&R, and the environmental things that one can do to prevent disease, like safe drinking water, like hand washing facilities, like spacing of bunks so that you don't breathe the other person's meningococcus and get meningitis. A lot of things in medicine that are best prevented and to which physicians can make a real contribution, but only if they understand what it takes, particularly understand the non-clinical aspects of medicine that are involved in prevention. Well, 3 months is not a master's degree in public health, much less a residency in preventive medicine, but it sure does jumpstart your career. And in the Army, that's all you got. And so then I got sent to Germany to be a preventive medicine officer in a combat division, the 24th Infantry Division, which was being trained to go to Vietnam. And my job was to understand enough about the life and life space of the soldiers who were going to go so that I could train them on how to keep themselves from getting sick. That was my job, to put together the training programs and to sell prevention. Now, selling prevention to an 18-year-old boy who's going to go out there and fight and kill is not an easy job. And although, you know, I was a physician and I thought much too highly of myself, as physicians tend to do, it's pretty humbling to get out there and having the guy's eyes roll and fall asleep and put their feet up on the desk saying, "Oh, come on, doc, I'm not going to do that." Or basically, without saying, that's for sissies or cowards or I can't be bothered. That's basically what their body language told me. And so putting together programs which would have resonance with people so that they could do the right thing to prevent themselves from getting sick became a wonderful professional challenge that I had never encountered in medical school or as an internist trainee. But I sure learned it. The week before the division was to be transferred to Vietnam, I got orders from the U.S. Army headquarters in Heidelberg that I was not to go with them to Vietnam, but I was to stay in Germany, and I got transferred to be the public health director for the middle third of Germany for 50,000 American soldiers, their spouses and families and dependents for the Frankfurt, Germany Medical Service area. And so for 2 years, after a year in Augsburg with the 24th Infantry Division, I was public health officer, chief of preventive medicine is what they called it, for the 97th General Hospital in Frankfurt. Judy and I took our wonderful daughter's, God's father's gift and made 2 babies during that time, which was just wonderful. I can assure you that we watched each one through his and her 3rd month anniversary with great fear. wondering if it was going to happen again. But we didn't lose another. And they grew up to be lovely adults who continue to lighten our lives all these years later. Both German, or at least thinking of themselves as German as well as American. That is to say, they were both born in Germany. And so our son is named Max, after Maximilianstraße, which was the street right up from where we lived. Anyway, I digress. Being a preventive medicine officer for the middle third of Germany was basically the job of running a health department, a public health department. But remember, I'd only had 1 year of postgraduate medical education, that as an internist and an intern in internal medicine at that. So I had, and then this 3-month wonder program. So at the end of those years, I had to decide whether to re-up in the military. I love being in military preventive medicine. You learn an awful lot about medical ethics in preventive medicine. More about that in just a second. Because your job is to often intervene on behalf of people who don't know that you're intervening for them and may not even want you to. So understanding the ethics and politics of social change as it relates to health is part and parcel of what being a public health person was all about. And I knew that I had no training in that area at all. So I decided to go back and get a master's degree in public health. And maybe even a residency training in preventive medicine. I went to my mentor from Yale, who by then was professor of medicine at Oxford, and he said, good for you, that's what you should do, and go to Harvard. So I applied, got in, and asked the Army to send me. And to make a long story short, they would have sent me, but couldn't guarantee me enough time to get a master's degree and a residency. And I felt I needed that. And so I got out of the Army. But not as an unhappy soldier. I was a happy child, a happy college student, a happy medical student, despite all of the unhappiness in internship, a happy intern, and I loved the Army. It was wonderful for me. But I knew I needed the training. I couldn't get it in the Army, and so I resigned my commission in 1968 and went back to Harvard to get a master's degree in public health, and little did I know, residency in preventive medicine, and because I had these 2 years in the bank for education, a doctorate in public health as well. When you think about public health, you need to think about the collection of things, efforts that society undertakes on behalf of the people to create conditions in which they can be healthy. So who the heck are we to do that to and for people without them even knowing we're doing it? Basically, every day in public health is a research project. It's an experiment. It is trying ways in the face of uncertainty to create conditions in which people can be healthy. It's a very complicated area. And we do so because we elect governments to secure these rights, including the right to life, liberty, and the pursuit of happiness. You may not know that Jefferson actually said, and without health there can be no happiness. But that means that in addition to all those other things, we want governments to create these conditions in which we can be healthy. But they do so in our names, often behind our backs, and with sort of an implied assent or consent. So what are the principles that underlie doing that? Well, they're exactly the same principles that underlie doing research. You have to respect the dignity of the individual, equity and justice, and always work to create a situation in which the benefits exceed the harms. Does that sound like beneficence or non-maleficence, dignity and equity, the three basic principles of the Belmont Accords that drive and undergird all of research ethics? Well, they also drive and undergird all of public health practice. That's what we have to do because we often are doing things without really having all of the evidence it takes to do the right thing right. And so public health practice has the same fundamental precepts as all research ethics do. The ethics of public health practice require these safeguards. Often our IRB is an elected board of commissioners or an appointed board of health. but our job is to bring our bright ideas to them to be sure that they don't violate these fundamental principles and educate them in the principles so that they can protect us. It's very much the same as the dynamic in clinical research, where often researchers find themselves educating their IRBs, not just being policed by them, and health officers find themselves educating their boards of health. So the concepts are the same in public health protection and what we end up doing in public health. Did I do research as a public health officer? Well, every day, because there's so much uncertainty in what we do. We don't know what will work to protect the public's health. We aren't exactly sure what the balance is between the doing good that we do and the harm that we do in the process. Witness all of the uncertainty around immunization and the concern about autism. Incidentally, a misdrawn concern, but nonetheless one in which you have to balance the possibility of harm from immunizations. There is some against the benefit from immunization to the individual and society, and how you balance those will determine which immunizations you advocate in what sequence when. Well, it's the same logic. Who gives us the right to do it? Well, we have a set of government institutions which tell us what we need to do, but basically the permission to make that intervention in the community is given by a community oversight board with accountabilities. So you have to monitor the impact of that public health intervention and report back evidence-based data that what we're doing makes a difference. And of course, in the case of public health, this also justifies the expenditure, because the money could be going to building roads or institutions. A very tough set of concepts, but one which made it virtually seamless to me, whether it was research or demonstration or program. It didn't really much matter. It all required the same undergirding. Within my first 7 years as a public health officer, I started off as director of medical care, and then when the public health director retired, I became health officer, and when his boss was fired, I became human resources director for Multnomah County and the city of Portland, Oregon. And during that time, we undertook all sorts of innovative projects, which some might have called research, because they involved the application of new practices in the community. For example, there was in Portland a very active gay community, and they had a serious problem with syphilis and gonorrhea. And almost no one wanted to hear the condom story. So we created a program to go into the gay steam baths, screen for sexually transmitted diseases, educate around them, and increase condom awareness. Was it an experiment? You bet. Did we have informed consent freely given? Sure. We at least made it clear that we were there and people didn't need to come unless they wanted to come, and if they wanted to come, here were the interventions we were going to exercise. Did we have accountabilities? Sure, to the Board of Health. Was there an IRB? Was there a protocol? Was there a final report? No. Was that an experiment? Sure. Was it ethically protected and conducted? In every way. But it didn't have an IRB. After 7 years as health officer in Portland, I was recruited. It was one of those moments that you never forget, where the phone rings and you don't turn it down because it was from a doctor. I was recruited to be health officer for the state of North Carolina. And I didn't say no. I had done the medical director, health officer, human resources director job in Oregon. I had a wonderful time. It had been a fabulous 7 years. We had our fourth child and took on a foster child. We were a family of 5, 2 dogs and an exchange student. And I still said yes. And so during the month of December of 1978, we drove across the country, and I started as Commissioner of Public Health in North Carolina on January 1st, 1979. It was a wonderful experience. Did we do experiments in the State Health Department? Every day, because public health is all about creating circumstances in which people can be healthy and doing your best, instituting new practices and evaluating them. Did we have IRB review and approval of them? No. Was I also responsible for the IRB for people who thought that what they were doing was actually research? Yes. Did I have research proposals brought to me by medical students and public health students all the time, and we reviewed them and applied all of the Belmont principles as you would as a public health official, except we didn't have an IRB. The IRB was our research staff with me as the chair. But you can bet we reviewed them as any IRB would. It's just that because there was no federal funding, we were at liberty to exercise our own IRB for work that involved our patients or specimens or activities. Remember that those were the early days of university IRBs, so if they were students, they went through their university IRB too, but they couldn't come through us without a separate ethics board review. So it's not that these projects didn't have IRB review at their institution, but they also had my ethics board review, where our principles were not unlike the IRB principles, except that we were thinking in different terms for beneficence, because we were thinking of the aggregate benefit to society as opposed to just the individuals involved, and the risks to programs, not just the risks to individuals. So that was we were essentially a parallel ethics review board. I was public health director in North Carolina from 1979 through 1981. There's a very tough transition story which involved a whole set of turnover in state employees, and I was part of that for a change of political winds when the governor elected to run for the Senate, and he had a whole bunch of people from out of state, Yankee boys, and needless to say, we all departed. Again, I thought my life had ended. Here I had planned to be the state health director in North Carolina forever, I guess. Never occurred to me that it would end, and certainly never occurred, since I'm a pretty ethical person, full of integrity and careful and smart enough, and doing all the right things right by the book, it never occurred to me that I would nonetheless be on the street. But I was on the street. With 4 little children and a foster daughter and 2 dogs and an exchange student in a big house in Raleigh. I undertook the career transition. It is a long story, and I'll spare you all the details, but it includes going back to medical school for a 3-year retread program as an internist, just in case I couldn't get a good job as a public health doctor, because I could always go back and be an internist. And my mother, when she was encouraging me to get proficient in German, pointed out that, and if I failed in medicine, I could always teach German. So I just was buying insurance. And while I was there, I got a call from Win Singleton, who was the medical director of a drug company, the U.S. headquarters for which was in North Carolina, called Burroughs Wellcome, the U.S. affiliate of the Worldwide Wellcome Foundation. And Win said, our safety director has just told me she's retiring. And we have an opening. I see your resume here on my desk, and I see that you have epidemiology in your background. Would you be interested? Well, it was a drug company. And there's an awful lot of prejudice against drug companies in the world, and I had it. I thought drug companies pushed unnecessary medicines through the unwitting gullets of unwilling patients through the hands of incompetent doctors, and who used the drug because the drug company bought them pizza. I mean, that was my stereotype of what drug companies were all about. Wrong, 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 and wrong. Drug companies, at least Burroughs Wellcome, were the most rigorous, most careful, most highly scientific, and certainly most ethical of enterprises our world has ever known. They were just amazing. The science there took my breath away. And so did the guy. Win Singleton was great. It turned out his boss, the director of R&D, was a fellow Washington University alumnus whom I had known when I was in medical school. We hit it off. And so I created the first department of epidemiology in the industry at Burroughs Wellcome. It was the department of, the section of product surveillance. I said, well, maybe I should be a department head if I'm coming from being state health director. Wynn said, sure. What do you want to call your department? I said, how about epidemiology and surveillance? He said, how about product surveillance and epidemiology? I said, sold. He said, fine, you're a department of 1. And there it was. Product surveillance and epidemiology became the first department of epidemiology in the pharmaceutical industry. Upjohn had a program. It was the only other one in the US. Roche had one in Europe, but it was basically an idea that was beginning to gel in 1981. And so here, the challenge was to create a whole new program of research in the pharmaceutical industry with an uncharted course. People hadn't been doing epidemiologic research within the pharmaceutical industry. If anything, because of the passion for the well-controlled blinded randomized clinical trial with separation of efficacy endpoints of p less than 0.05, which was the road to truth, non-experimental research, what epidemiologists do, was considered junk science and essentially been thrown by the side of the road, which was wrong. That was just wrong-headed. It's clear that well-controlled blinded randomized clinical trials with separation of efficacy endpoints of p less than 0.05 are good, and it's good science, particularly if there's a protocol and it goes through the IRB and there's good informed consent, all of the things that PERMA knows to do by heart. But nobody knew how to do observational research, the public health research side of things, because it wasn't interventional. So the rules didn't apply. We had to carve it out of whole stone. I thought I was going to work for Burroughs Wellcome in the pharmaceutical industry for 1 year while I got a real job. And I retired 15 years later to the day, still young and very happy and very satisfied with an extraordinary career, having been director of a small department at Burroughs Wellcome, and then the same department for worldwide Wellcome, and then vice president for epidemiology and other functions for the worldwide Wellcome organization, and then eventually on a transition team after Wellcome merged with Glaxo in 1995, and I stayed around for the transition and then took early retirement, but 15 years to the day. So the most important thing I did at Wellcome was to create the ground rules for ethical conduct of public health research inside the pharmaceutical industry. There were no rules. There was no oversight body. There was no national professional society. All of that had to be built, and we built it. I was part of it. It was an extraordinary 15 years. The International Society for Pharmacoepidemiology had me as its first president, and now as a lifetime honorary fellow. And we created the rules for ethical conduct of non-experimental drug research conducted by the pharmaceutical industry. Rules for oversight, rules for IRB review, standards for good conduct, all of those didn't exist because people disregarded observational research. And many people thought it wasn't necessary because observational research, after all, didn't involve doing something to someone. It meant getting data that somebody else had and taking and summarizing it across populations to be sure that there was no big problem emerging in the treated population that wasn't seen in the non-treated population. But you weren't randomizing, experimenting, getting consent from individuals. So what are the ground rules for ethical conduct there? Well, of course, the underlying principles are exactly the same as the underlying principles for safeguards in a clinical trial. Beneficence, dignity, social justice, except that they have to be applied at a population level where you have to be concerned about things like data privacy or using people's data without their permission. How do you get it retrospectively? And if you don't, then what are the rules that will protect them from having their data exploited without depriving society of its opportunity to know? And the pharmaceutical industry, from its duty to learn, part of the transition from 1981 to 1996 was a realization in the pharmaceutical world, aided by the courts, that not knowing was not an excuse. In the 1970s, Johns Manville was found negligent for its failure to learn that asbestos caused mesothelioma. Their defense, we didn't know, so we couldn't be held accountable, was considered inadequate because they could have known and should have known. The tobacco industry could have known and should have known and conspired not to know. And the pharmaceutical industry was going down the same road in 1981. By 1996, when I retired, and now I still consult with the pharmaceutical industry and it's been a joy to watch this field grow. Nobody would ever dream of intentionally not knowing whether a drug was causing a problem in a population. That's just, the standard is, of course, your job when you get a new drug approved is to know what you don't know and build a program of continuing research, often non-experimental, not involving the sorts of things that most people think of IRBs reviewing most of the time relating to drug research, but of course requiring the same kind of oversight after the drug has been approved, so-called pharmacoepidemiology. So that's what I did up until 1996. Then I retired. I retired quite precipitously and unexpectedly. On Friday, I came into a senior staff retreat, and my director pulled me aside and said, "Hugh, we need to talk." I said, "Sure, James, what do we need to talk about? Hope things are okay." You never take for granted that your boss loves you, even if you think he should. And James said, "I just have come from a board meeting, and I've learned that the people from Wellcome will lose their pensions and be working for Glaxo with golden handcuffs for up to 7 years before they can build back the pension that they had. Or they can retire on Monday." So I retired with no plan. On Saturday, I called my friend, the Dean of the School of Public Health, and said, "Michelle, I've got some good news and some bad news. The bad news is I'm retiring. The good news is I'm available." And Michelle said, "Well, I've got some good news for you, and that is, as dean, I can create a clinical faculty appointment of 1-year duration with no permissions from anybody, and I hereby appoint you clinical professor." And so on Friday, I was international vice president for epidemiology, surveillance, and policy research for the largest drug company in the world. And on Monday, I was a freelance clinical professor at the University of North Carolina School of Public Health, where I still am on the adjunct faculty some 17 years later. It's been a very happy third career.
In your career as a public health officer, were you involved with Primer in any way, or did you know of Primer's mission or activities as educating in research ethics?
The answer is no, I wasn't involved with Primer. Primer concentrated primarily on IRBs, and I worked for a drug company, so we weren't university-based. We didn't have our IRB. We contracted multinational clinical trials. The IRB was often seen as our nemesis because they kept trying to undo the consensus that we had built for the multinational clinical trials. We went to regional or national IRBs, and the local IRBs didn't like that because there was this tug of war between national or international IRBs and the university-based institutional review system. I knew all about Primer because I've been involved at the national level with the National Pharmaceutical Research and Manufacturers of Association, PhRMA, where I was chair of their medical section, and I endorsed Primer. Primer came to me and asked for an endorsement and a recommendation that drug companies should understand and embrace Primer, should support Primer, should send their researchers to Primer, and I said, sure, great idea. Didn't happen, though. Didn't happen. Primer was basically university-oriented and IRB-oriented. At least the stereotype was. Now that I know Primer better, I understand that Primer is far more than that. But in those days, that was kind of the stereotype. And the pharmaceutical industry really saw the university IRB system as a problem to be dealt with rather than the solution to any problem. So helping to build that bridge, yeah, was part of my legacy with pharma. So I knew Primer, and you know, I had many friends who were involved with the university IRB community and more with university-based ethics and international ethics, including one of the backbones of American research ethics since the beginning, a fellow named Bob Levine, who had been a graduate fellow when I was an intern at Yale. I'd known Bob since 1965 and had the greatest consummate respect for him as an ethical thinker, as a person who goes beyond the mechanics of institutional review boards and really thinks about the ethical underpinnings of learning, not just research. Hence, all of the analogies with public health as a learning community. Well, that's Bob Levine's legacy, far more than just IRBs. And I knew he was part of Primer, which again made the bridge to Primer and the need to be sure that a respect for underlying ethical underpinnings was fundamental to the ethos in the pharmaceutical world much easier, because I had this great confidence that any organization that had Bob Levine in it had to be worthy of listening to.
Why would Primer want someone of public health background on their board? To get this new perspective, to get...
Well, wait a second. Is your question, why did Primer want me? The answer is, beats me. I am an ethical thinker, an advocate for ethics in practice, but I'm a public health practitioner and academic. And although I do a lot of research and have done a lot of research, most of my research was not IRB-able, or if it was IRB-able, it was other people pursued it through their own local IRB, and often it wasn't subject to an IRB review. When I discovered that the first day I went to work at Wellcome, my new boss, Wynn Singleton, pulled me aside and said, young man, he always called me young man, even the day he was retired, when I was no longer so young, he called me young man. Would the public health doctor in you be impressed if I told you that we think we have a treatment, if not a cure, for herpes? And of course, a grin came across my face, and I said, absolutely, it is one of the scourges of the STD world. And he said, well, we do. This tie is the molecule of acyclovir, Zovirax, the drug that breaks the chain because it's acyclic guanosine. The herpes virus thinks it's guanosine, but it has one cycle broken. It incorporates the guanosine into its nucleus and can't reproduce. A great custom-designed drug, one of the brilliant breakthroughs in medicine, a legacy of the Wellcome story. But it was going to be approved for the treatment of herpes without a lot of experience at the population level to be sure that the beneficence principle hadn't applied at the population level. Totally compliant with any IRB review for randomized, 2 well-controlled blinded randomized clinical trials with separation of efficacy endpoints of p less than 0.05, but no data about what the long-term impact of that drug would be in the population. No data about what the impact of that drug would be on the fetus. Here you have a drug that blocks the reproduction of a virus. Who knows what it's going to do to the reproducing genome in the human? So the FDA solution was, well, say it's not approved for use in pregnancy. Put in the label, there's no data about use in pregnancy, proceed with caution, or do not use. But that doesn't change the way people behave. So if you're going to have a population intervention, you need to put together a program of research to be sure that the reproducing genome doesn't result in birth defects. So we had to figure out how you do that in the case of acyclovir. And thus, the program of acyclovir post-marketing epidemiology was born, a set of studies which were landmark at the time and benchmark to this day. So they continue into my post-Wellcome world. I continue to advise, having gone to work at the university, on international pregnancy registries for new drugs that are marketed, where we still, like the acyclovir situation, don't know. We have the opportunity to know. We have the methods to know. And so we put together projects in which we can know. Do those projects require an IRB review? The answer is maybe. Do we get one? Yes, we get one. One internationally for the world, because there's no university collecting data. There are no patients who get randomized. So we get one IRB waiver, basically, of informed consent and an approval of a protocol, and then we monitor drug exposure worldwide.
Tell me what you bring to the Primer table. Why are you there, and what insights do you offer, and what are those discussions like? Do you inform them, or how do they inform you?
A good friend of mine wrote a book about public health, which he called A Spy in the House of Medicine. And maybe I'm a spy in the House of Primer. That is to say, I'm really kind of an outlier. I'm a public health practitioner, professor, academic, whose research is primarily outside of the IRB arena. But I am a student of and practitioner of the boundary between practice and research. When is what we do in a public health or a clinical epidemiology or non-interventional observational drug study enough like research so it needs the ethical protection of institutional review? What are the other mechanisms to provide institutional protection? And when is the IRB just a nuisance? When we misusing the IRB isn't well suited for us, and it's not necessary anyway. Understanding those boundaries is part and parcel of what makes Primer great. Primer isn't just about lockstep implementation and regimentation of the IRB system. The IRB system is a tool to create conditions in which we can be a learning society with human subjects protections. There are lots of others, and I guess I am the specialist in other. I think I bring to Primer, in addition to a pretty long and strong career in practice at the boundary between research and practice, and education on the boundary between experimental and non-interventional research and ethical protection, and oh yes, education around the ethical practice of public health and medicine, which is also part of what makes Primer great. And so an ethicist without a capital E. I have no portfolio in the IRB world at all, but I bring a lively interest in being sure that we do the right thing right, and we don't use the wrong tool to do the right societal job. Now, there's another answer, and that is, I think Bob Levine, with whom I had worked for many years on these boundaries internationally, knew me, and wanted that kind of perspective on the board, and he nominated me. Nobody else on the board would even have known me, because I'm not part of the IRB world. And so he had to put together the argument that it would be useful to have a person who understood drug development, pharmaceutical companies, practice and practice boundaries, practice of medicine, practice of public health ethics, all of that portfolio that we don't spend much time on in Primer. But remember, Primer is about public responsibility in medicine and research, and being sure that the ethical interfaces get addressed was something that Bob has stood for years. Just as I have a passion for the ambiguities between practice and research, I also am persuaded that the world of research as we have known it is going to change dramatically in the next 10 years as we understand what being a learning society really is. A learning society in the old days just meant, well, we learned from our mistakes and fixed them and maybe built in quality improvement, quality assurance. And then we began to have a love affair with quality improvement and quality assurance. Then we began to have an evidence-based love affair when we saw how grave the medical errors are out there, how many mistakes medicine makes that it never pays attention to, how much we continue to do what we used to do because we did it, not because it was the right thing. And so the medical community in quality assurance and continuous process improvement has revolutionized in the last 10 years without an evolving institutional review mechanism to be sure that what we do is ethical. And in the process, got in trouble for applying continuing improvement techniques from one community in another community because we thought maybe it would be applicable there too. And then we thought we'd collect data to be sure it was applicable and sounded like research. And suddenly the IRB shut them down when in fact it was just quality improvement work, doubtless totally exempt from and irrelevant to the IRB review mechanism. The quality improvement revolution is changing the definition of research dramatically, but not as dramatically as the electronic medical record. Now, all of our medical data are available in big data. We may not like it that the National Security Agency has every telephone number or every Gmail account, but those accounts are there. And they're very useful for tracking espionage and subversive activities. And we don't have the framework in 2013 to manage those data in a way that make us comfortable that our privacy, our dignity, our secrets aren't being invaded by big government. Well, we have the same problem in medicine, where we have electronic medical records, where all of our information, for good or bad, warts and all, is now available to wonks like me who know how to work computers and don't want to do experiments on you. I want to know at the population level whether exposure to acyclovir is resulting in more cancers than people who are otherwise the same but don't get acyclovir. And I don't care about the individual. I want to look at the population level. Well, the electronic medical record will allow me to do that. But in the learning society, the electronic medical record will allow me to do so much more. I mean, basically, I know every medical transaction that's occurring in that population. So what if I changed the way I did clinical research? Introduce new drugs into a population, but instead of having these labor-intensive, chory-bory clinical data forms and some person with a green eye shade typing data in, I just got the data in the medical record, which was already there electronically anyway. And it just came to me the same way the record would come from the diabetes clinic visit. In fact, you could be getting a new diabetes drug and all your record would have would be the identification that you were in a study. P.S. If the drug was randomized, it would just have the randomized number in your record. And then when the study was over, all the data would already be collected. There'd be no data forms, there'd be no anything. Just this population would get the new drug and that population would not, and you'd see whether there was a difference. A learning society, a society in which clinical research, the old experimental research world that we knew that created the IRB, is over. And we don't have the paradigms to embrace that new world. It is a huge challenge. So quality improvement challenge, huge. Electronic medical record and continuous learning, or learning health care system, maybe broadened with my public health background, I would add, to the learning health system, where the public health data and the private health data are simply the same. But why would anybody ever have to report a case of meningitis to the health department when the lab gets the culture for meningococcus and those data are electronically transmitted the same day to the health department? Nobody reports anything. They're all in the same transparent data sets. All of these notions of who tells whom what under what protections have to be revisited.
So the challenges for Primer are to deal with these emerging issues.
They'd better, or those issues will overtake us. Or we'll continue to have seminars on a model that has the humble researcher coming in with his protocol or with her protocol and having the data collection forms or clinical research forms reviewed by somebody. There won't be a CRF. There will be collection of data electronically as part of the ongoing medical record system. We're not thinking in those terms of the learning health system yet. We will. We're there. I mean, I don't mean to diminish my friends in Primer. Primer is right there. Primer is right on the cutting edge of doing all of this. Our annual meetings are getting the word out and helping the sector to rethink it. It is the sector that needs Primer's leadership to think through new research paradigms and new ways of human subjects protection in the face of this revolutionary new world. And before I get off that subject, there's also the genomics revolution that's coming along right on top of the quality assurance and electronic medical record revolution. So there are three sort of parallel new data worlds out there, all of which have their own ethical dilemmas, all of which require a rethinking of our nation's approach to human subjects protection. Enter Primer and its challenges for the next decade. Primer is, in my view, but then I'm a little prejudiced since I'm on the board, the leading policy research advocate or policy ethical protections advocate in America, if not the world. There are a lot of others, and they would probably take it personally that I think Primer is a cut above them. But I think every effort needs a lead. And Primer has the opportunity in this next century, in the next decade at least, several decades, to lead as society rethinks human subjects protection in the face of these informatics, knowledge development, and genomics revolutions. In order to do so, we need to be resourced and resourceful. We need to be new communicators. Did I mention that education is also undergoing a revolution? And we're right on the forefront of that, of learning how to do distance learning and webinars. I don't think we've begun to see where web-based learning even simultaneous web-based learning with multiple faces on the same camera and voice-activated question and answer, and so forth. And that technology is still emerging, and Primer is trying to stay ahead of that one as well, because a leadership organization has to have 5 attributes. We have to be visionary. We have to be able to envision what the world will be like 10 years from now and skate to the puck, not to the old player. Then we have to be strategic. Everybody's going to have something there. What is it that is our unique value added? Well, our unique value added is as convener, is as creative thinker, is as preposterous proponent. Just get ideas out there, like the seamless drug approval when you don't have randomized trials of drugs anymore because they're all in electronic medical records. Even if it's not going to happen, just get it out there. Somebody has to take that lead. Primer can take that lead. Then muster the resources, build the partnerships, and develop the communication, the big 5 aspects of leadership. If Primer's to be the leader, then we have to be strong on all 5.